Hello, everyone. I'm going to give 5 more minutes for more people to join, then we'll start. So we'll start at 7:05. Thank you. Okay, good evening, everyone. We are going to start now. So we are going to go through the article. What I've done is that I've written, I have some notes written in this article, and also I have another Word document here where I have some answers written on it. But what I'll do first is to go through the article and then we'll go through the word note, and then you see some of my answers. Also, everyone must have his calculator because we are going to go through some calculation so that we know what the decision tree is. Thank you. So I'll start with, please, if you have any question, let me know. I'll start with questions first, then I would go through the article. Any general questions, concepts, anything that you want to know? Okay, so if there's no question, then I'll start. So in reading the article, the first step you need to look at is the topic. What is the topic talking about? So what you really need to look at is, so for the topic, you look for two things. You have to look for the type of pharmacoeconomic studies that is being studied. So it must be mentioned in the article. So you have to look for what is being compared. So I can see here that this article did the topic very good because it mentioned what is being compared, that is PPI and then the H2 arrays. And this is a head-to-head comparison. And it also mentioned the type of pharmacoeconomic studies that was being done. It was cost-effectiveness analysis. So what you do in the initial stage is to look at the topic and then look at what is being compared. And then you expect that in the article, they will mention the type of pharmacoeconomic studies that is being done. So from here, I would say that the topic was very good. It has the type of pharmacoeconomic studies that was being done. And also it mentioned the comparators. That's a head-to-head comparison of PPIs and then the H2 arrays. Okay. So in the abstract, you can see that I've underlined few things here. So first of all, in the abstract, we looked at what the objectives or what the objective of this study was. So this study was to compare the cost effectiveness of two prophylactic pharmacological options, which are the PPIs and then the H2 arrays. So my first question to everyone on this platform is, what is the difference between cost effectiveness analysis and cost minimization analysis? Because, for example, if we think that this is cost effectiveness analysis, why is it not cost minimization analysis? Anyone can unmute and then answer if you can. What is the difference between cost minimization and then cost effectiveness analysis?
Good question, Milton.
Mhm.
Is it the outcome?
Okay, the outcome, what has it done? I'm sure today I was in class. I'm sure these are the questions that she's going to ask in the exam. So we need to be ready for these type of questions. So the answer to the question I asked is that what is the difference between cost effectiveness and then cost minimization analysis? They all measure clinical outcomes. So the cost is the same, but the clinical outcome is the difference. So in cost effectiveness analysis, the clinical outcome should not be the same. But in cost minimization, the clinical outcomes are the same. And you need to prove this with statistical analysis. So you need to have a p-value that really shows that these two drugs that are going to be compared are the same. So if these two drugs are the same, then it is cost minimization analysis. If the drugs are not the same, then it is cost effectiveness analysis. In this case, it is cost effectiveness analysis because there are two different drugs, which is the H2 arrays and then the PPIs. So this study can't be a cost minimization analysis. Rather, it is a cost effectiveness analysis. So that is the answer to that. And in the objective, they stated why it is not, they will not tell you, but they stated why it is not cost minimization, but rather it is cost effectiveness. So for example, he said PPIs and then H2 arrays, they present varying pharmacological efficacy. So based on this, you will know that the study being done is cost effectiveness analysis instead of cost minimization analysis. Because if it is cost minimization analysis, we expect that this will be the same. The pharmacological efficacy will be the same. But here they stated it, they said it's different. So we are looking at cost effectiveness analysis. Okay. So I'm going to give a brief overview of what this research is all about. So this research is really about patients in the ICU who are at high risk of developing stress ulcers. So, and in this case, the stress ulcer is our primary outcome. There's a secondary outcome, which is the ventilator-associated pneumonia, which is the secondary outcome. So our primary outcome, the main thing that we are looking at here is prevention of stress ulcer bleeding. So in this case, the patients are ICU patients. They are at high risk of stress ulcers. So we are going to give these two prophylactic agents, and we'll look at which one will be able to prevent these stress ulcers. So I've said it already, they are at high risk of developing stress ulcers. We are giving pharmacological agents, prophylactic agents to prevent stress ulcers. So our outcome will be stress ulcer prevention or prevention of complications. So this is a general overview of what is going on here. So I would want to go through some of the notes I've written. So for example, here, I want to know what are the types of decision trees? How many types of decision trees do we have?
2.
Okay, and what are they?
Simple and Markov.
Okay, how do we differentiate between simple and then the Markov models?
With the time,
Okay, what is the time?
this study was for 60 days only, and Markov must be for more than a year.
Okay, perfect. So I want us to read this article this way because each line, each sentence has a question that can be asked. So here, if you look at the method, it said we constructed a decision tree with a 60 days time period for patients at high risk of developing stress ulcer bleeding, and then they were receiving these medications. So this tells us that they will use decision tree, simple decision tree instead of Markov models. Because if it is Markov's, we'll need more than 1 year. So we are using simple decision tree. Okay. And the group, they were grouped into 3 disease states. There is those with stress ulcer bleeding, ventilator-assisted pneumonia, and then those without complications. And they also took the payer's perspective. So there are 5 types of perspectives: the payers, the employer, the provider, the patient, and then the societal. But in this case, it was the payer's perspective. When we go to the method, I will explain why or what will tell you or what will help you know whether it's payers or it is employers or it is whatever. And also they did sensitivity analysis. So we'll go through that as well. So I'll start with the introduction now. So in the introduction, they were just talking about the fact that patients in ICU have high risk of developing stress ulcers. And they know that research has shown that there are 2 drugs that can be used to prevent these stress ulcers. And these are the PPIs and then the H2 arrays. But the problem with these drugs are that even though they can prevent the development of the stress ulcers, they also have a side effect, which is the ventilator-assisted pneumonia. So the gap or the reason for this whole research, so this is the highlighted point, this is the yellow part, this is where they explain why they are doing this research. So they said that there's a low incidence of stress ulcer bleeding that is coupled to the high cost of this complication. And because of this, they need to do a cost effectiveness analysis comparing the PPIs with the H2 arrays. And then these are their objectives. We therefore performed an economic analysis to quantify the cost effectiveness impact of the two therapeutic prophylactic approaches. So in the introduction, what you need to do is, what you need to know from the introduction, briefly. You need to know the general overview of what is going on. So they spoke about the fact that patients in the ICU are at high risk of stress ulcers. And then they spoke about the different drugs that they will be comparing. And they explain the gap in literature or their rationale for doing this research. And these are their objectives. So the next thing that we'll look at is the method. Do you have any question on the introduction and also the abstract? Any questions?
Milton, can you move a little bit up the document so we can see the notes that you have on there on the right?
Okay.
Thank you.
So here I was just explaining what cost per diem is, and it's just cost per day. I will explain it in the method. That's why I'm not focusing on this now. So, okay.
I have a question, Milton.
Okay.
So you mentioned that if it's same drug will be cost minimized analysis. So same drug, you mean same category or exactly same drug, like just omeprazole, different doses?
Thank you for your question. So what they need, you need to, what standard you need to set before you can do the cost minimization is that in the cost minimization, you have to prove that the two drugs, it can be different drugs, but the two drugs should be the same. And you have to prove that with a statistical analysis. So you need to get a p-value. So let me open her example and show you what I mean by this. Can you see my screen, please?
Yes.
Okay. So for example, in cost minimization, what they do is, for example, this is the same drug. This one is talking about, I think, meropenem, but it is talking about the fact that you can use it. There's traditional dosing and there's alternative dosing. So in the outcome, this is the outcome and this is the p-value. You need to show that these drugs, they have the same outcome. For example, this is an antibiotic. So they can more like treat the same kind of bacterial infection. And you have to prove that with a statistical test. So in this case, even though they found this difference and then this, from statistical point of view, they saw that there is no difference. So in cost minimization analysis, you have to prove that the two comparators are the same. Either they are the same because they are the same molecule and they have the same effect, or they are different molecules, but they have the same effect. So you need to prove that they are the same. In doing that, you have to know that the effect will cancel out, and the effect will cancel each other out. So the effect of one would be the same as the other. So this part is going to be 0. That's what I'm talking about. I'm saying that if it is cost minimization, what you need to do is you need to provide evidence that the outcomes are equivalent. And you should state that it is statistically the same. And this is an example. The same drug, different administration. This is traditional dosing and this is alternative dosing. And they saw that the p-value was 0.238, which is more than 0.05. And therefore, the effect here is the same. So in this case, you can't do cost effectiveness analysis. You rather do cost minimization analysis. So I was comparing that to our studies, where from the beginning, they stated that the effect is not the same. The effect, they said they have different pharmacological effects from here. So since they have different pharmacological effects, we can't do cost minimization. We rather do cost effectiveness analysis. Does it make sense, Mitra?
Yes, thank you very much.
Okay, so we'll go through the method now. So for the method, what we will look at is, so it's just saying that for this study, like I said before, the study is done with patients who are at high risk of developing stress ulcer in the ICU settings. And they identify these patients from the nationwide inpatient sample, that is the NIS 2008. And I've written this thing here because when I was doing the research, I saw that this particular data from this institution is a retrospective and it is observational. So just know that if you see the nationwide inpatient sample 2008, it's a retrospective and it is observational. It is retrospective because it is looking backwards, and it is observational because they didn't administer any intervention. If they administer intervention, then it becomes more like something like clinical trials or something. Okay. So in this way, we know that the costing step. So I'll go through the costing step, but I just want you to know that one of costing step 2, this is the costing step 2. They had their data from the nationwide inpatient sample, and then it's this one. They use payers perspective because they use the perspective from Medicare, Medicaid, and then private insurance. So I've written here payers perspective to just show that they were from the payers, Medicare, Medicaid, and then the private insurance. Also, so with this, I said the data is from the nationwide inpatient sample. But after getting the data, they were supposed to diagnose the patients who are at high risk of stress ulcer, and then who has the stress ulcer bleeding as well. So they used clinical trials. And then this clinical trials was this is the clinical trial. It was done with these kind of patients. And then in the clinical trial, what they did is they have a way of diagnosing the patient. So they used that same way in this clinical trial to diagnose these kind of patients. And it was validated by, they have a clinician expert. And then his name, I think, is AB. I think he's the first author, which is the clinician expert. So for the diagnosis, again, they use something called International Classification of Disease, which is the 9th review clinical modification codes. And then they use other sources from the NIS database as well. So that is how the population were recruited. So they first of all looked through the NIS for the number of patients that they were looking for, and they used the randomized clinical trial to help with the diagnosis. They used the ICD-9 CD codes to help with the diagnosis as well. For the design of the research, what they did is they did a decision tree, which we'll talk about very soon because I have it here. With the decision tree, they used this program here to do the decision tree. And also for the drugs that were used, they used omeprazole 40 milligram daily, and then that can be oral or IV. And they did famotidine IV 40 milligram twice daily as well. And then the treatment, like I said already, the treatment were grouped into complicated and then no complication. For the complication, it was further divided into two, which is the stress, ulcer bleeding, and then the ventilator-assisted pneumonia as well. And they did the payer perspective. So for the source of, so they did probabilities as well. And for the source of the probabilities, they did a search from 1990 to September 2011. And this was computerized medical literature search. And these are some of the databases they searched. So I've highlighted these ones for you to know which databases they did the search in. And here they did the inclusion criteria. The inclusion and then the exclusion criteria. This is, if you fall within this, then probably you'll be able to participate in the studies. If not, you are out. And this is another way to tell you that they are not really doing the cost minimization analysis. They said trials. So for the studies, they said trials comparing only different dosing regimen of the same molecule were excluded. So because they were doing cost effectiveness analysis instead of cost minimization analysis, they excluded all studies that just studied the same drugs or the same molecule, then they excluded those ones as well. So I just want to go through the method and I'll come back to the tables and all that, and I will explain that. So here they did the length of stay and then the cost. So a specific length of stay and then per diem were assigned to each of the three groups. So I've mentioned that we have three groups already. We have the complicated and then the uncomplicated, or the not complication. The complication has the stress, ulcer bleeding, and then the ventilator-assisted pneumonia. For the no complication, we would also look at what they did. So for the cost, so all that I've mentioned here, the probability, and then the probabilities, and also the hospitalization, that was costing step 2. Now we are going to look at the costing step 3. Costing step 3 is where they would put a value, a monetary value on each hospitalization. So something like per diem. Per diem is cost per day. So we'll look at the sources they used for this this costing step. That's costing step 3. So they said they only included costs, hospital costs. And then what is interesting here is that they assume that all the pharmaceutical costs were considered included in the hospital cost. So the hospital cost included the pharmaceutical cost. And let's review this. We have about 4 types of costs, which is the direct medical, direct non-medical, and then indirect, and then the intangible. For the hospital cost, it is a type of direct medical cost. Also, the pharmaceutical cost is also a type of direct medical cost. And if you look at the perspectives, it is the payer's perspective can cover the direct medical cost. Patient perspective can also cover direct medical cost. Providers can cover direct medical cost. But in this case, they were interested in the payer's perspective. So they just included direct medical cost. In a situation where they include something that is not direct medical cost, so for example, they include cost of traveling from one part to another, cost of hotels and all other things. Those ones are not direct medical costs. Those ones are direct non-medical costs. So then the perspective will change. So in class today, she said she's going to test us on these. She's going to give us a scenario and then we'll decide whether it is payer's perspective, provider's perspective, or the patient's perspective. So it depends on which cost was included. Okay. So the next thing that I want to also discuss is the time adjustment. So you can see from here that I've written here time adjustment. So they did time adjustment. The time adjustment they did was they used the consumer price index. Now there are two ways of doing time adjustment: discounting, and then there is the standardization. For the standardization, we use consumer price index to do the standardization. But for the discounting, we use the discounting factor. So in an exam, if you see anything like consumer price index, know that we are doing standardization. And in standardization, we are bringing the cost from old cost to the present cost. So the data they used was in 2008. So they standardized all the costs to 2010. So that is the standardization they did. That's the time adjustment they did. So this is where they did the time adjustment. This part is telling us about the population of the patients that were selected for no complication, those with stress, ulcer bleeding, and then those with ventilator assisted pneumonia group. So for example, in those with no complication, there were 94,865. And then those with stress, ulcer bleeding, there were 1,088. And then those with the VAP, there were 232. So what they did is they checked in the database, they checked the number of days patients were admitted. So they grouped the patients into 3 health states, which is the stress, ulcer bleeding, the ventilator assisted pneumonia, and then the no complication. They did, and they saw that those with stress ulcer, they normally, averagely, they spend about 24 days in the hospital. Those with the VAP, they spend an average of 42 days in the hospital. And then those with no complication. So in these patients, they've received the prophylactic agent and they are doing well. So they spent an average of 14 days in the hospital. They chose the 60 days because they saw that about 97.6% of the patients spent an average of 60 days or fewer in the hospital. So that is why they used that 2 months period for the studies, because they saw that that's the average number of days people spend in the hospital. Now for the cost, they saw that the average hospital cost for no complication was 41,600. And then for the stress ulcer bleeding was 65,500. And for the VAP was 137,700. And yes, so they did the cost effectiveness analysis, which we'll go through in the results section. So I want to go through the sensitivity analysis, and then we'll go to the table and then we'll start the decision tree, start doing the decision tree. So for the sensitivity analysis, they did one-way sensitivity analysis, they did two-way sensitivity analysis, and then they did the probabilistic sensitivity analysis, which is also called a multi-way sensitivity analysis. So with this, we'll go through the tables and I'll go to the decision tree. So for the decision tree, like I've explained already, there are a group of patients who are at high risk of developing stress ulcers. These patients, they are here. And then the researchers decided that they'll give them prophylaxis against these stress ulcers. So they gave a PPI and then they gave the H2 arrays. In the PPI arm, they measured those with no complications. So in this patient who were at high risk of stress ulcers, in this arm, they had no stress ulcers. They didn't have any complication, including they didn't develop ventilator-assisted pneumonia as well. So this part has no complication. The other arm, which is the complication arm, were divided into two. There is a part that has stress ulcer bleeding, and there's the part that has the ventilator-assisted pneumonia. So I'm going to show you where I had these numbers from. So these are the probabilities for the complication arm and then the no complication arm. So if you look at table 1, this table 1 talks about the probabilities that were used in the studies. So for example, the one, remember that these are in percentages. So what you do is that you divide each of these by 100, and then you get it in, you convert it from the percentage form. So patients with stress ulcers were those that develop stress ulcers with PPI, the percentage is 1.34. And those that developed stress ulcers with H2 arrays, the percentage is 6.61. Those that developed the VAP with the PPIs was 10.33. And then those that developed the VAP with the H2 arrays was 10.23. So based on this, what can we say about the probability of developing stress ulcer bleeding and then the VAP based on the PPI and then the H2 arrays? Here, are we looking for something? Are we looking for a big probability, or we are looking for something small?
Something small.
Okay. So yes. So here, the smaller, the better. So for example, here, based on this, we could see that the PPI is very effective in reducing stress ulcers. The H2 arrays, the patients in H2 arrays, they had more stress ulcers because they had 6.61. And then the patient in the PPI, they had 1.13, which is less stress ulcers, and then which is more stress ulcers. For the VAP, even though it's almost the same, but you could see that the PPIs has a side effect of causing the pneumonia more than those in the H2 arrays. And I remember that these are estimates. So in the research studies, they found that, for example, the 1.34 was within a range of 0.7 and then the 0.3. So in the sensitivity analysis, we are going to vary this, for example, this number, we will vary it within this 0.7 and then 0.3. We are going to also vary this between 6.1, 6.61. We will vary that between 4 and then 9. And then for the 10.33, we'll do it between 8 and then 14. Just we'll do the same thing with this. So the probabilities, this probability will come back to it later. This has been multiplied already. So this is an arm. So we'll come back to this one later. So the actual probability for the decision tree is here. So for example, it said the only probabilities in the models are the overall rates. That's for the PPI and then the H2 array groups. And then the proportion of these that represent either an outcome of the stress ulcer bleeding or the VAP. From the above probabilities, they appear in figure 1. So for example, for the complicated or for the complication rate in the PPI arm, they saw that this is for the complication. So let me show you where the complication is. So this is the complication in the PPI arm. This is the complication in the PPI arm. They saw that 11.67% developed this kind of complication. So I wrote that here. I converted the 11.67% to 0.1167. I just divided the 11.67 by 100, and I had this. And then remember that this here, everything should add up to 1. This, within this arm, and then that arm, everything should add up to 1. So I just subtracted this from 1, and I had 0.883 as the probability of no complication. So let me repeat again. For the probability of no complication, I just subtracted this. This was stated here. This one is here. So 11.67, which is for the complication. And I subtracted this from 1, and I had this. Okay. Let me go to the next one. The next one is the complication for the H2 arrays, which is 16.93. So for the 16.93, this is the complication. So I put the 16.93 here. So all that I did again was to subtract the 16.93, which I divided it by 100, and I subtracted this from 1, and I had 0.8307 as my probability for no complication. What it means is that the H2 arrays, they are able to prevent development of either the stress ulcer bleeding or the VAP in 83.07% of the population. And then the PPIs were able to prevent complications in 83.33% of the study population. Okay, so the next one that I'm going to talk about is the proportion of complications that are the stress ulcer bleeding or the VAP. This is in the PPI arm. So in the PPI arm, the complication was the complication for the stress ulcer bleeding was 11.5, and then the complication for the VAP was 88.5. So let me show you where. So this is the PPI arm, and then this is the patient with the stress ulcer bleeding. So I put the 11.5, I just divided it by 100, and I have 0.115. And then for the VAP, I divided it by 100 again, and then I had 0.885 as the probability of developing VAP in the PPI arm. So for the H2 array arms, we also had 39% of patients developing the stress ulcer bleeding. And then you have 61% of the patients developing the VAP. So let me show you how I did that as well. So this is the 39%. I just converted the 39, I just divided the 39 to by 100. And this is it. This is 0.39 for the H2 arrays. And then for the VAP, I just did 0.61. Does it make sense? Do you all understand? Do you want me to go over again? Who wants me to go over again? Do we all understand? Can I continue?
Yes, sir.
Yes, thank you.
Okay, let me continue. So I told you guys that I'm going to come back to these numbers here. This, for example, this, which is the stress ulcer bleeding with the PPI arm, they had 1.34. You can get this value by multiplying this here, the complicated, that's the complication of the PPI. When you multiply the complication of the PPI by the probability of complication of the stress ulcer bleeding by 0.15, you get this number here. This number here. Let me go again. Now for the stress ulcer bleeding with the H2 array treatment, they had 6.61. You can get this number by multiplying the complication, this one 0.1639 by 0.39, and then you get this. You get the 6.61, which, remember that I said this is in percentage, so you need to divide it by 100 to put it in the decision tree. So for the VAP with the PPIs, they had 10.33. Now you get the 10.33 if you multiply this here by this. So if you multiply the 0.1167 by the 0.8835, you get the 10.33. The same thing for the 10.23. You get the 10.23 if you multiply this by that, by this one here. So that is why they have these probabilities. So we don't have to put this directly into the decision tree, but we'll use it when we are doing the calculation for the total weighted cost, and then that one will come later. So I just want us to go through this. So for the cost, it can be found here. So for the cost, they said the average hospitalization costs were this, that is 41,600 for no complication. So let's go to the decision tree, and then where there's no complication, we'll put the 41,600 in the decision tree. So in the decision tree, you can see that I didn't do this one, I just did this one, so that we'll go through this one together, we'll do the calculation together. So in the decision tree, the cost for no complication was 41,600, and this is where I had this number from. So for the costs, cost for stress ulcer bleeding was 65,500. So I'll go to the decision tree and I'll put the 65,500 wherever there is cost for stress ulcer bleeding. So you can see it here as well in the H2 array arm, and then the PPI arm as well. And then the 41,600, you can see the 41,600 here, and then that. And then this is the cost for the ventilator assisted pneumonia. You can see 137,700. Let me show you where I had that from. And the same thing here. So I had that number from here. So it said the cost for the VAP was 137,700. So that's where I had this number from. So I would want to share my other screen, and then we'll go through the calculation for the decision tree. And then we'll come back to the article. We'll continue with the article, but I want us to finish this first. Can we see my screen?
Yes.
So when I was doing the research, I explained why this is a full pharmacoeconomic studies. So there is cost, and then the cost is hospitalization costs, and this includes pharmaceutical costs. There is an intervention, which is the PPI, and then the H2 arrays. And this is a head-to-head comparison because we are comparing two drugs. It is not really a new drug and something like a standard. Just we are comparing two drugs together. So this is a head-to-head comparison. Now the outcome was complication averted. This can also be stated that this is just complication prevention. So we are looking at, so in the beginning I said the study was done in patients who were at high risk of developing stress ulcer. So we give them prophylaxis, and then we check those that did not develop the complication of the stress ulcer bleeding. So the outcome was complication averted. And then in the study, we'll get there, not yet, but in the study, they used probability of no complication as their outcome. So we'll get there and I'll show you what I'm talking about by this. But I just want you to know that the outcome, remember that in the quiz, she will normally trick you and then say the outcome is cost per maybe complication averted. This is not an outcome. This is a clinical outcome. So whenever you see something like that, you have to choose cost complication averted or complication prevented or no complication. You don't have to choose cost per something because that is not an outcome. So I've explained this one already. The patients were grouped into complication, and then those in the complication arm are the stress ulcer bleeding and the VAP. And then those with no complication, these patients are at high risk, but they don't have these complications. And this is a clinical outcome, and it is a CA. It is a CA because these two drugs, they don't have the same effect. If they have the same effect, then it becomes CMA. Okay, so for the costing step, the first thing that I want us to look at is the type of cost that was involved. So I've explained that already, which is hospitalization cost, and this includes pharmaceutical cost. And this is a direct medical cost. They took the payer's perspective, so I've said that already. For the number of hospitalization, the data, number of hospitalization data source. So the costing step 2, they had their information from.
I'm sorry, what was costing step 1?
So costing step 1, normally it's 2 things. It is the perspective and then the type of cost.
Okay.
So the type of cost here was cost for hospitalization. And this cost for hospitalization includes pharmaceutical cost.
Okay.
And I showed you in the article where you can find that from. And this is a direct medical cost. Remember this, so I told you that the type of cost, there is direct medical cost, there is direct non-medical, there is the intangible, and then there's the indirect. So the indirect is normally productivity lost, where we look at the absenteeism and then the presenteeism. Absenteeism is when you don't go to work at all. Presenteeism is you go to work, but you can't perform the normal work. For the perspective, I said there are about 5 perspectives. There is the payer's perspective, there's the provider's perspective. So the provider's perspective, think about it as the hospital, what the hospital in general is doing. And then there's the patient's perspective, there's the societal perspective, and then there's the employer's perspective. If it is employer's perspective, normally they will do the indirect medical cost. So if you see indirect medical cost, normally it's either the employers, the patient, or the societal perspective. But this one, it was just direct medical cost, and it was stated in the article that they did payer's perspective. For the number of hospitalization, that's costing step 2. Costing step 2 is just to quantify the number of times patients stayed in the hospital. So in the article, I showed you that, for example, those with no complication, they stayed for 14 days. And then those with VAP, they stayed with, I think, 42 days. So we are looking at where they had that data from. So I've written here length of stay. So the length of stay is the costing step 2. So they mainly had that data from the NIS, which is the Nationwide Inpatient Sample 2008, which is the one that gave us the length of stay. And then I've added these here, which will just tell you where they had. I told you that this, for example, this ICD-9-CM was what they used for the diagnosis. So I've written here diagnosis, just to tell you how they were able to diagnose these patients. And also, I told you about the fact that they used a clinical trial to help with the diagnosis as well. Okay. And for the probabilities, they had, so I showed you, I don't have the data, I don't have the names here, but I showed you which database was used. And I've highlighted that in my article. So for example, they use the M-base, the midline and all that. So that's where they had their probabilities from. And these are the costing step 2. Any questions? Do we have any questions? Do we understand? We don't understand.
Yes, thank you.
We're good. Thank
You're welcome. So let's go to the costing step 3. Now the costing step 3, they have to put a value on the number of times you stay in the hospital. So for the costing step 2, we are saying that they would have to find the number, just the count, the measurement. They will measure the number of times you will be in the hospital. But in the costing step 3, they have to put value on, for example, a day. If you spend a day in the hospital, how much are you going to pay? So that is costing step 3. They put in value, and this is monetary value on the number of times you stay in the hospital. So that, I said, is called the per diem. So in the article, I showed you where you can find the per diem, and then the per diem they had it from this source, and then the per diem is just cost per day. So each day, how much it costs the patient to be in the hospital for a day. And then to calculate the total cost, what you have to do is that you have to just multiply the step 2 and then the step 3 together. So for example, in this case, we are going to multiply the step 2, which is the length of stay, times the per diem cost. That's cost per day. So that will give us the total cost. And then for the time adjustment, I've explained that already. I've said that if you see the consumer price index, don't think about any other thing than thinking about standardization. If you see discount factor, think about discounting. And normally the discount factor is either 3 or 5. So they standardized from 2008 to 2010. For the sensitivity analysis, we'll go through, even though I've not gone, I just want us to go through this. So for the sensitivity analysis, they varied all the parameters within their 95% confidence interval. So I showed you, for example, in the probabilities, I showed you the range where they are going to vary the numbers. So they did one-way sensitivity analysis. And this one-way sensitivity analysis, they perform the sensitivity analysis for all the variables. And they did tornado diagram. We'll go and then we'll explain that, not now. They did two-way sensitivity analysis as well. And then in the two-way sensitivity analysis, I'll explain it when we get there. What they do is that they vary two variables together. So in one way, they vary just one, they hold everything constant, and then they vary just one variable in the one-way sensitivity analysis. In the two-way sensitivity analysis, what they do is they vary two variables together. So in this case, they varied the incidence of pneumonia in the PPI group, and then the incidence of pneumonia in the H2RA groups. We'll look at it when we look at the threshold analysis for the two-way sensitivity analysis. For the probabilistic sensitivity analysis, they did two things. They did the incremental cost effectiveness plane, which is also called the Monte-Carlo method. And they also did cost effectiveness acceptability curve. We'll explain that, so don't worry about it. I just want you to know what, so far, we are almost done with the method. So that's why I'm going through this, so that we'll finish the method and then we'll go to the results. So in order to do the calculation, I went through this step by step so that everyone will understand. So for example, they identify the per diem cost and then the length of stay for each patient group. So for example, no complication was this, and then the number of, the length of stay was 14 days. For the stress ulcer bleeding, the cost was this, and then the length was 24 days. For the VAP, the cost was 3,310 per day, and then the number of days was 42. But the reason why I have these numbers here is that when I did the calculation, I had these, which is not exactly the same as what is in the article. So I used from here on, I just want to show you that if you really want to do the calculation, this is what you will get. This is the numbers, this is the cost. So this, for example, this is the cost for 14 days of no complication. It's 41,900 2. But in the article, they said it's 41,600. So remember, we are going to use this. We are not using this. I just want to show you that if you actually do the calculation, this is what you will get. But this is what's in the article. So we are going to use this. The same thing as this, and then the same thing as that. So the probabilities, for example, the probability of no complication was 88.3%. And then I divided that by 100 and I had 0.883. The probability for stress ulcer bleeding was 1.34, and I divided by 100 and I had this. Probability for the VAP was this, and I divided and I have this. So in order to calculate the total weighted cost, what you have to do is that you have to multiply this, which is the cost, by the probabilities. So for example, the total weighted cost for the no complication was I just took this number. Remember that I didn't take this number. This is what I got when I did the calculation, but in the article it stated this, so I'm using this instead of this. So just remember so that you don't be confused. So I said 41,600, that is this times the probability of no complication. This is the probability of no complication, which gave me 36,745.28. Remember that in class today, she said she normally wants the cost to be in 2 decimal points. And she wants the probabilities to be in 4 decimal points. So remember this. So the total weighted cost for the stress ulcer bleeding was 65,500 times the probability of stress ulcer bleeding, which is 0.01. And the total weighted cost for the VAP was this, and then the probability was this, and I had this. So in order for me to do the calculation for the total weighted cost for the PPI arm, all that I did was to take this, that, and then that, and I added everything together, and I had this. So today I went to and then I asked there about this. This is not exactly the same as what is in the article. It's a bit off, but she said it's okay because she doesn't expect us to get the same answer as this one. So let me show you where in the article they did this calculation and they had the total weighted cost for this. So this is the total weighted cost for the PPI arm. So let me show you in the article. So in the article, yeah, so this is what I was talking about. This is the number of this is the individual cost, and this is the length of stay in the hospital. Okay, so this is the total weighted cost for the PPI arm. This is the one I did. This, you can see that it is 51,000 something, but I think the one I had was 51,847 or something instead of this. So this is what they had. Okay, let me go back to the article. So the next thing that we'll do together so that we all understand is to do this calculation together. So we are going to do the calculation for the, so I have everything together. We'll just have to point things and then put things inside. We are going to do the calculation for the H2 arrays. So I will let you do the calculation and then tell me what the answers are, and I'll put it in. So I have the same steps. I have all the steps here. I have the cost of no complication, the number of days, the cost of stress ulcer prophylaxis, stress ulcer bleeding, and then the number of days, the VAP, the cost, and the number of days. Then I have the calculation. I did this and I had these numbers. So I told you that these numbers are not right. So we are using this. So all that you have to do is to just multiply this by this, and I'll put the answer here. And then we'll look at the total weighted cost for the H2 array arms. So first of all, let's do the cost for 41,600 times 0.8307, and then let's look at what that will give us, and I'll put it here. So please, if you get the answer, let me know and I'll put it there, please. Do we all agree with this number here?
Yes.
Okay. What about the next one? So 65,500 times 0.0661. Do we agree with this number here?
Yes.
Okay. What about the last one? Do we agree with this number as well? Do we agree with this number here?
Yes.
Yes.
Okay. So let's add everything up and then let's get the total weighted cost for the H2 area arms. Do we agree with this number?
Yes.
Yes.
So this is the total weighted cost for the H2 array arms. Let's compare our answer to what they had in the article. So this is 53,000 and 97. So let's see in the article what they were. So in the article, they had 53,099, which is almost the same, but it's not the same. So this is what they had. How do we feel about the decision tree? Is it making sense? Do we understand? Do you have any questions? I'm looking for questions. What questions do you have? If you have any question, please unmute. I can go back and then explain it again if you want me to. Do we have any questions?
No, Milton.
So then, if you don't have any question, then we'll go through the next step for the decision tree. So after getting these numbers here, so that's what am I doing? 1 minute. Okay. I made a mistake. So after getting this, why am I doing this?
Milton, you have a question on the chat.
Okay, let me check. Sorry. How many questions do you have? Please, I'm looking at the questions now.
But the article don't have that, they don't have that information, the total weighted cost, right? We need to
Well-
calculate it.
Which one?
Then the article, because I see that Stephen asked if she asked for the total weighted cost, we will go with what we calculated or the number in the article.
Yeah, so I spoke to her this afternoon, and she said she's going to be specific. For example, if she wants the one that we did, so in the cheat sheet, if you are going, please have the this calculation with you, because she said she's going to be specific. She can ask you what is the total weighted cost for the H2 array from the article. In that case, you would use the one in the article. If she's asking you about the total weighted cost that you calculated, then you are going to provide this one. Does it make sense?
Yes.
Just like, remember when we were doing it in class, she can say that in class, what is the weighted, what is the total weighted cost in class? Or what is the total weighted cost in the article? So it depends on which one she's asking, then you just have to do which one she's asking for. So we have this. Please, do you have any more questions? Okay, so if you don't have any other questions, then let me see. I think I have another question. Okay, yes, no question. So after getting these numbers, what you need to do is to do the cost effectiveness steps. This is where you make your decision. So what we have to do is to, first of all, arrange the costs in the ascending order. So I'll go back to the article and then we'll continue and then we'll come back to that again. I hope so far so good. You all understand what I'm trying to put across. Okay. So let's come back to how the effectiveness was measured. So the effectiveness started from here. So in all that we are doing, we are just doing the cost. What is the effectiveness? What is the effect? What is the outcome in these studies? So he said the effectiveness was expressed as the probability of no complication occurring during the hospitalization. So let me go to the decision tree and then show you where they got their effectiveness from or their outcome from. And remember that I said this is a clinical outcome. So their outcome was the probability of no complication. So this is their clinical outcome. So in the beginning, I told you that these drugs are to prevent stress ulcers. So among these two drugs, which one is able to prevent stress ulcer the most? So for example, the PPI was able to prevent stress ulcers in 0.883, which is 83.33%. And then the H2 arrays was able to prevent stress ulcers in 83.07%. So which one is more effective? If you are comparing,
PPI.
yes, so the PPI is the most effective one because it's able to prevent the most stress ulcers in more people than those with the H2 arrays. So that is our outcome, and this is a clinical outcome. I've said that already. So from here, this is where I had that information from. So he said the effectiveness was expressed the probability of no complication. Remember that here, they didn't talk about any cost per complication, cost per something. They just said complication. So it's the probability of no complication. They didn't add any cost. Okay. So he said the cost, so the rest, I don't think it's too important. The cost were those tabulated for a complicated or uncomplicated hospital stay. The main outcome was the cost per averted. So that is where I had. So you see, this is going to confuse you. Don't let this confuse you because we are not looking for cost for an outcome. So they said the cost was the cost per averted complication. So the outcome, let me repeat again, the outcome is the averted complication. That is the outcome. The results are reported as cost effectiveness and incremental cost effectiveness ratio. If a strategy is more effective, but also more costly than another, or if not, the model simply point out the strategy that is dominated. So the dominated strategy is the one that is both less expensive and then more costly. And it was shown in the, I will go there right now. So from the table, I've shown you how they had their effectiveness. So this is their effectiveness. So their effectiveness is from the probability of no complication. In other words, the ability to prevent complication. So the PPI was able to prevent complication in 88.3%, and the H2 arrays was able to prevent complication in 83.07%. So let's go back to how to do the calculation for the cost effectiveness. So now that we know so the PPI and then the H2 arrays. So we are going to arrange the costs based on ascending order. So in order to do that, we know that this is less. So I'm putting this one here. And this is more. So I'm going to put this one here. And then we are going to add up their we are going to add up their outcome, which was, this one is, I think, 0.8833. And this, the outcome was 0.8307. So based on this, we can conclude from this that this here is less expensive, more effective. And this is more expensive, less effective. So in the article, you hear something like the H2 array was dominated. It was dominated because it is more expensive, but it is less effective. So let me show you this. So if you look at if you remember something like this, the cost, incremental cost effectiveness plane. These are the quadrants. So there's quadrant 1, quadrant 2, quadrant 3, and then the quadrant 4. We do the calculation for the ISA. So in this study, you will see that they didn't really do any calculation for the ISA. The reason was that ISA calculation was done, it should be done in quadrant 1 and then quadrant 3. Because here, this is the costs, and this is the effectiveness. So if you're in this quadrant, what it means is that you are more expensive, but you are more effective. If you are in quadrant 2, you are more effective, less expensive. And this is the quadrant that says that you are dominant. So for example, the PPI is in this quadrant. So the PPI is dominant. The PPI is in this quadrant, is dominant. Because we can see from these two that it is less expensive, which is here, and it is more effective, which is here. So the PPI is in this quadrant. For the H2 array, it's in this quadrant. It is more expensive, and then it is less effective. So then it is in this quadrant. So H2 array is in this quadrant. So that's why the H2 array is dominated. So this one is the dominated quadrant, and this one is the dominant quadrant. So the PPI is dominant, and then the H2 array is dominated. I said that the ISA is normally calculated in this quadrant. Quadrant 1, and then quadrant 3. Because in quadrant 1, you have to decide whether you pay the extra cost for the extra benefits. In quadrant 3, you have to also decide whether you want to pay the extra cost for the extra benefit. But for quadrant 2 and then for quadrant 2 is dominated, and quadrant 2 is dominant, and then the quadrant 2 is dominated. It is dominant because the PPI is less expensive, more effective. So you pay less and then you get more. For the H2 array, you pay more and then you get less. So it is quadrant 4. Do we understand this basic concept? And then do we know which quadrant is dominant, which quadrant is dominated, and then in which quadrant we need to do the calculation for the ISA?
Yes.
Okay, yeah. So the next thing, so I've spoke about the ISA already. So we'll do the calculation for the ISA, but in this particular one, we are not really interested in the ISA because of where the PPI and the H2 array falls. So we'll do the calculation for the ISA. In order to do the calculation for the ISA, we just have to subtract this from this, and then that from that. And then so I'll show you in the article, they did the ISA, I'll show you the article where they did the ISA. So in the next step, in the cost effective step, we have to determine whether there is first order dominated or not. So in this example, is there any first order dominated or not?
Yes.
Mitra, can you explain why you think that there is first order dominated?
So in the first order, we're checking the cost and effectiveness. So when is the cost increasing, which is H2R, RI blockers, they have a more cost, but the effectiveness is less. So is the first order dominated?
Good, thank you. So I've explained that already. So I said the H2 array is in the 4th quadrant, which is dominated. So in this case, there is first order dominated. This, we can't do second order dominated because in order to do second order dominated, we need at least 3 comparisons. We need at least 3 things that we are comparing. This one, they are comparing just 2 things. And also, we can't, the H2 array is already dominated, so we can't do the second order domination or the second order dominated. So the ISA, I said we'll do the calculation. So the ISA is change in costs. So ISA is equal to the change in costs over the change in effectiveness.
Milton, sorry to stop you, but can you repeat the second order dominated? I missed that point.
Okay. So for the second order dominated, in the first place, we can't do the calculation for the second order dominated because in order to do that, we need at least 3 things that we are comparing. So in this case, we are comparing just 2 things. So that is the first step that we can't do the second order dominated. But apart from that, we already know that the H2 array is already dominated already, so we don't need to even go further. But we can't do it in any way because just we need, for example, we need 3 different drugs to do the second order dominated. Nakin, does it make sense?
Yes, it makes sense. So we don't have second order dominated.
No, we
here.
don't have second order. We don't go there at all. We just stop at the first order dominated.
Okay, got it.
Okay. So here, in order to do the ISA, we just have to subtract 0.97.31 minus 51.8747, sorry. Thank you. Result 51, 8, 4, 7.39. Okay. And that will be divided by 0.8307 minus 0.8833. So I found that this is so please can you do the calculation for me? 530 5309.7.31 minus 51847.38. What is the answer?
Two 3764.25.
2, 3,
3764.25.
4. Okay, what about
Oh, I gave you the final answer.
okay, so that is the ISA. Okay, no problem. So I'm sure we can all do the calculation for just all that you need to do is to subtract this from this and then that from that and then get the final answer. So this is the ISA. This is the ISA here. Let's compare this one to the one that they had in the article. So let me go back to the article and see what they had. So in the article, they had, for example, in the article, so this is their ISA in the article. This is the ISA. So 23,767. So how do we interpret this at this ISA? How do we interpret this ISA? Who wants to try? Mitra, do you want to try? Okay, try.
So I think we have to say if we want to use H2 blockers, we have to, I don't know, pay this amount extra to get this effectiveness.
For the complication,
Okay, can you reframe it again? Because I don't know if you understand. I don't understand. I don't understand what you are saying. So say it again, like say it well. Because remember that this is opposite of what we do in class. The one we do in class is you pay this amount, which is the one we do in class, normally it's in quadrant 1. You pay this amount to get this extra benefit. But this is different. Because this one you are paying more and then you are getting less. That is why that ISA is in negative. So if you can see, the ISA was reported in negative. The reason is that you are paying more, you are getting less. So what you need to do, what you are doing here is that you are paying extra 23,000 and something, and then you get less effect. So that is why that ISA is in negative. Does it make sense?
Yeah, makes sense.
Do you want me to explain it again, or that is okay with you?
As you explained, like we have treatment effect is less compared to the cost we spend on the PPI.
Yes.
So very little treatment effect we get as the output.
Yes.
So that's why we get the negative value for the ISA.
Yes. So what they want to say is that comparing the H2 arrays to the PPI, you pay more and then you get less. But the one we used to do in class, you pay more and then you get extra benefits. This one you pay more, but you don't get that extra benefit. So that is why we said that the H2 array is dominated. So if you look at here, they didn't really report the ISA. They just said H2 array is dominated. In order to do the calculation for the, so here they were saying that, for example, the cost difference between the PPI and the H2 array is 1,250. It was reported here. And then here I've underlined this one. So here what they are saying is that the cost effectiveness analysis showed that the PPI strategy exhibits $1,250 lower average cost per patient with greater probability of not developing a complication. So all that they are saying here is that you pay this extra amount for the H2 arrays, and then you get less. That's what they are saying here. So to be more precise, average cost per no complication. So if you really don't want any complication, you spend less in the PPI group. So in the PPI group, you spend 58,700 to get no complication. But if you don't want any complication in the H2 array groups, what you have to do is you have to spend more, which is 63,921. This is how they had this numbers here. The numbers here was just to divide. They divided this, that is the cost effect ratio. They just divided 51,841 by 0.8833, and then they had this. So this is the cost you need to pay if you want to prevent complication. So if you pay this amount, no complication for the PPI. And then the same thing, they did the same thing here. They divided the 53,099 by 0.8307, and then they had this. So if you don't want any complication in the H2 array group, you need to pay this. So all that this table is telling us that the H2 array is dominated because you need to pay more to prevent complication. You need to pay less to prevent complication in the PPI group. The effectiveness in the PPI group is more than the effectiveness in the H2 array group. And also the cost is less in the PPI group than the H2 array groups. So all that they are saying is that PPI is dominant. The PPI is,
Sorry, I have a question. So those costs there in the table for the $51,849 and $53,099, it's gonna be the weighted cost?
yeah, so this is the weighted cost, the one that we did, the calculation that we did.
Okay.
So
Okay,
here,
thank you.
this is the weighted cost here.
Okay.
So
Thank
this
you.
is after the decision tree. So they did the decision tree, and this is what they had as their costs. So in the exams, if she's asking you about the total weighted cost in the article, this is it. They did the decision tree and everything, and then they had this as the total weighted cost for the PPI. And they did this, and they had the total weighted cost for the H2 arrays. And then for the effectiveness, like I said already, they did probability of no complication, and this probability of no complication for the H2, for the PPI. And this is probability of no complication in the H2 arrays. Mitra, you have a question? Okay.
Yes. So right now we cannot say the statement because if this one is dominated, but it just example, if it's not dominated and its cost effectiveness is more than the PPI, how you say that the statement? You say H2RI compared to PPI, we have to pay 23,000 for getting the effectiveness. How you say that the statement?
So compared to, for example, This one, normally they just say it's dominated. They don't really give it in a statement, but I'll try to explain it in a statement for you. So in the article, they didn't really state, for example, you know, the previous articles, they will tell you that compared to this, you have to pay this extra amount to get this benefit. But in this case, you are paying an extra amount, but you are not getting any benefits. So to state this in a sentence form, you just have to say that compared to the PPIs, in the H2 arrays, you have to pay an extra, 23,767 to get maybe like a lower effect or to get smaller effects than in the PPI. Does it make sense?
Yes, thank you.
Yes. But normally what they do is they don't report it this way. They just say that the H2 array is dominated. They don't really say all these things. They said H2 array is dominated or the PPI is dominant. That's what they say.
Sorry, Milton, can you repeat that, please?
Okay. So let me go back to this and then use this to explain. Probably this one will do. Okay. So normally if it is in the first quadrant, this quadrant, they will tell you that to get the extra benefits, you need to pay an extra amount. So you pay this extra amount to get this extra benefit. If it is in the first quadrant, if it is in the third quadrant, it's the same thing. You need to pay this extra amount to get this extra benefit. But in the fourth and then the first quadrant, we don't say that. We just say that, for example, the H2 array is dominated or the PPI is dominant over the H2 array. That's what we say. But if you want to, for example, just because we did the calculation for the ISA, if you want to really talk about the ISA and then explain it in terms of the ISA, then you can say that compared to the PPI, comparing the H2 array with the PPI, you need to pay extra, you pay this extra amount, which is 23,764.25. This is the extra amount you pay for the H2 array. And then when you do that payment, you get, for example, so you get less effect because we know that the effectiveness of this H2 array is less than that of the PPI. So I think in the article they did the difference between the effectiveness. So look at the effectiveness. This is the effectiveness here. And this is the difference. You see, this is positive and this is negative. So you pay extra, you get a negative result. You pay extra, and then you get less.
Okay.
That is why the ISA is reported in negatives. So
Thank
the
you.
ISA here is in negative 23,767 because you pay more, you get less. Does it make sense?
Yes,
Anna,
thank
okay.
you very much.
You're welcome. Okay. Okay, so I have a question. Somebody said the ISA you got is less than the one in the article. Can you explain? Yes. So in the beginning, I told you that the numbers are not really the same. So if I don't know when you joined, but from the beginning, the numbers are, there is a bit difference. And it's the same thing. If you remember when we were doing it in class, we had a bit, not too different, but it's a bit different from what's in the article. So today I spoke to her about it and I asked her and she said, it's okay. In the exams, she's going to specify. For example, if she wants the one that we are doing here, the calculation that we are doing, she's going to ask you, give her the ISA for the one that you calculated. Or she's going to be specific, give the ISA in the article. So you just have to know which one you just have to read the question, understand, and then know which one she's looking for. So if she's looking for the ISA in the article, then this is the answer. This one here. If she's looking for the ISA in the one that we did, then you have to look for this. So just know which one she's looking for. So this is the ISA that we did. This one here. not just the ISA, you can see that all the numbers are a bit different. If you look at this is a bit different from the one in the article. And this is also a bit different from the one in the article. Do you have any more questions? No, it's not because of the negative. It's because, so when I was speaking to her today, she said they use some computer models and they do some averaging and all those things. So it's difficult to get the actual number if you are doing the calculation like this. So that's what she said. Do you have any more questions? So now we know based on all these, what is our choice? Which drug are we choosing? Based on all that we know now, what is our choice?
PPI.
Okay, so we are choosing the PPI because the PPI is dominant over the H2RA. The H2RA is dominated, so we don't want that. We want the PPI. That's our choice. So that is list of alternatives. So remember that the costing step, there are 5 steps. You arrange in the ascending order, and then you do the arrangement. After that, you determine first order dominated, and then you do the calculation for the ISA. We did second order dominated. This one, there's no second order dominated, so you don't need to think about it.
I'm sorry, for the first order dominated, what was it again?
So the first order dominated, what we are looking for is a drug that is more expensive but less effective. So the H2RA was more expensive and less effective. So it is first order dominated. Does it make sense?
Yes, thank you so much.
So for the second order, there's nothing second order dominated, so we don't need to think about it. And then we'll list the alternatives. So our choice, if we are basing our decision on just this, what we've done, our choice is the PPI. The PPI is the drug of choice. So that is our choice, the PPI. And then in the decision tree, we'll go back to the decision tree. This is where we will show our choice. And then remember that in the decision tree, they have different names. So remember that this is node of choice. This is node of chance. Do you remember that thing? And this is the terminal node. So our choice, we'll put our choice here as the PPI. So we put the PPI here as our choice. And this is the node of chance node, and this is the terminal node. And then remember that this is the branch 1. This is the branch 1. This is the branch 2. This is the branch 3. This is the branch 4. This is the branch 5. This is the branch 6. So this one in total, we have 6 branches. She can ask you the transition probability for branch 1. And then the transition probability for branch 1 is this. Remember, transition probability of branch 1 is this. She can ask you transition probability of branch 2. And then you have to multiply this by this to get the transition probability of branch 2. In order to get transition probability of branch 3, you multiply this by this to get transition probability of branch 3. The same thing, if you want to get the transition probability of branch 4, it is this, 0.8307. If you want to get the transition probability of, this is 4, okay, 1, 2, 3, 4. If you want to get the transition probability of branch 5, you multiply 0.1693 times this to get the transition probability of branch 5. And then the same thing, branch 6. And then remember that this is the total cost for branch 1. After multiplying the transition probability by the cost, you get the total cost for branch 1. And then to get the total cost for branch 2, you multiply the transition probability by this and then you get this. To get the total cost for this, you multiply this one by this and you get this. And then this is total weighted costs. You have to remember these things because if you don't know, she'll ask you and then you don't know what to do. This is called the total. So the total for the PPI is called the total weighted cost or the expected value. This is called the total weighted cost or the expected value. This, I said, is called the transition probability. And this is the total cost for branch 1. This here is the total cost for branch 2. And then this is the total cost for branch 3. I didn't do this one, so I'm not going to. You can just do it, this one, this part. And then remember the terms. This is the decision of choice. This one is a chance, and this one is the terminal node. And then right now we've decided that our decision is PPI. That is the drug that we are using. Okay. Now let's go to. So for the base case result, our base case result is that the cost is this, and then the effectiveness is this. The cost for the A2 array is this, and then the effectiveness is this. And then the cost to prevent complication in the base case is 58,699. And then the cost to prevent complication in the A2 array is 63,921. And then remember that we said it's dominated. So now let's come back to the sensitivity analysis. So for the sensitivity analysis, what kind of graph is this?
Tornado.
And what is it used for? What kind of sensitivity analysis do you use this graph for?
One way.
Okay, so one way. So on this graph, what are we looking for?
The parameters were sensitive to change the decision.
Okay, that's good. So remember that I told you we are going to vary the numbers within the 95% confidence interval. So here they did vary the numbers, the 95% confidence. So for example, this is an example. So yes, this is an example of the 95% confidence interval for the costs for the per diem of the SUB during hospitalization. So the actual, when they did the research, they saw that the actual cost is within this. This is the lowest end and then the highest end. So they varied the numbers between this and then that. And remember that if it is one-way sensitivity analysis, what they do is they keep all the other variables constant and then they vary just one. And this is what they did. So this bar here is they just varying the probability of the VAP in the PPI and then keeping all the other variables constant. And then they plotted it as this. And remember that this one, the one we did in class, normally they continue this bar together, but right now but remember that it's the same bar. This is the same as this one. This bar is the same bar. So it's just this. So that's why I wrote these things here. So it's the same bar. So this and then that, so these two bars are the same thing. So this graph, what we are looking for is what parameter is more sensitive. So after doing the sensitivity analysis, they did the sensitivity analysis for all the variables, but they plotted the most important ones. So they plotted 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So they just plotted 10, but they said in the article it was stated that they varied all the variables, and then they plotted just the important ones. So from this tornado diagram, the first one is normally the most sensitive parameter. So here, the most sensitive parameter is the probability of the VAP, probability of the PPI causing the VAP, which is the most sensitive parameter. The next one was the probability of the H2 array causing the VAP, which is the next most sensitive. And the lowest, the one with the lowest sensitivity is the per diem cost of the VAP, which is the 3,310. So this diagram, all that I want you to know is that the top one is the most sensitive. This one is the least sensitive. It's in this order. And also just know that this is done for just one-way sensitivity analysis. That's all I want you to know in this diagram. And then know that this bar here is they just varying one parameter and then maintaining all the other parameters as the same, and then they plot everything. And then they would vary the next parameter and then maintain all the other parameters constant, and then they plot, and then they do it for all the variables, and this is it. So with the sensitivity analysis, they saw that the base case only changes. It only changes in most cases, it's the same thing. The PPI is dominant, and then the H2 array is dominated. In most cases, that is what the base case analysis is. But there is a scenario where the base case can change, because remember that we said some of the variables are really sensitive to the sensitivity analysis. So here they found that the H2 array, it ceases to be dominated. So in this case, it's not dominated. It ceases to be dominated if this probability, which is, for example, this one here, the probability of let me go here. Sorry. Which is the probability of the PPI causing the VAP, which is 10.33. So it ceases to be dominated. If this probability here changes, then the H2 array is not dominated anymore. But you have to change that probability to 11.6% for the H2 array to be to cease to be dominated. Or if you decrease this parameter here, this is 10.23. If you change that to 9%, if you change that to 9%, then the H2 array ceases to be dominated. But even with all these, the PPI still remains more expensive and more effective. So all that this part is saying is that, let me go back to that diagram. Okay, I think I have it here. Where I showed you which one is which part is dominated and all that. So all that is saying is that if you change the 10.3 to 11.6, and then if you change the 10.32 to, for example, 6, the PPI changes from this quadrant here to this quadrant. It becomes more expensive, more effective. So it depends on you to decide whether you want to pay the extra, you want to pay for the extra benefits. So if you do that, so you have to know this one. You have to really know this. At what point does the base case changes? So the base case changes when the probability of causing the VAP in the PPI changes from 10.3 to 11.6. And also when it drops from the 10.32 in the H2 arrays to 9%, yes, 9%. In that case, the base case changes. But even though the base case changes, still the PPI is still the best because it is more expensive and then more effective. But in this case, it is no more dominant. Does it make sense? Do you have questions? Any questions? Okay. If there are no questions, let's go back to the next one that we are going to discuss is the threshold analysis. Which kind of sensitivity analysis do we use the threshold analysis in? Which type of sensitivity analysis do we use the threshold analysis? What type? At what point do we use the threshold analysis? Okay, let me go on with it. So remember that you have one-way sensitivity analysis and we have two-way sensitivity analysis. Both the one-way and then the two-way sensitivity analysis, we can use the threshold analysis. So the tornado is normally in just one-way sensitivity analysis. But for the threshold, it can be used in both one-way and then two-way sensitivity analysis. You have to decide based on what they did. That's what will tell you whether it was two-way or one-way, because the threshold can be used for both. So you can't just look at the threshold and say they did one-way or two-way. You have to know what they did. That will help you know whether they did one-way or two-way. Remember that in one way, we just vary just one variable and we maintain all the other variables. But in two ways, and two-way sensitivity analysis, we vary two variables at the same time, and then we just keep the rest. So in this case, they did two-way sensitivity analysis, and I'll show you what they did. So what graph is this?
Threshold.
Okay, so this is threshold. So this is how you know whether it was one-way or two-way. Remember that probability of VAP in the PPI group and then probability of VAP in the H2 array groups. These are all parameters that we just spoke about. So in this case, they vary two variables at the same time, and they kept the rest intact. So two variables at a time, and then they kept the same everything intact. And the base case for the probability of VAP and then probability of the H2 array was 10.33, which is 0.1033, and then which is for the H2 array was 10.23. Now, if we use the base case, what will be our decision? Our decision will still be the PPI, because if you plot, for example, the 0.1033 will be around this place, and then the 0.132 will be around this place. When you plot this on the graph, it would meet in the shaded area for the PPI. So the PPI still is our decision. But in the exam, she's going to test you. For example, if the base case, or if she gives you an example, and in the example, for example, she's asking you that the example is 0.0785875. That is our base case, and the probability of the VAP in the PPI was maybe, for example, 0.15. In that case, the decision changes, and this becomes our decision. This is just a hypothetical example. It's not part of it. I'm just saying that it depends on where the two plots will meet. Where they meet, you make your decision. For example, if the decision is 0.07875, and then the probability for the VAP in the PPI group was 0.125, then the decision will be the H2 array. So we are going back. I think they did that. They varied the variables, and then they had a decision. So we'll look at it and we'll come back to it. Okay. So here they said that threshold analysis for the probability of VAP shows that only when this variable exceed 15.6% for the PPI or drops below 5% for the H2 array, does the PPI strategy become dominated. So when they were changing the two variables, they saw that if, remember that the probability of the VAP in the PPI was 10.33. If they change this number here to 15.6, or if they drop the H2 array, which was 10.23, they drop that to 5%, then the H2 array will dominate the PPI. So in this case, the decision changes if you increase the probability of VAP in PPI, and then if you drop the probability of VAP in the H2 array, then the PPI becomes dominated, and then the H2 array becomes dominant. So here I said the stress ulcer bleeding probability has to increase by more than 5% for the PPI strategy, or drop by more than 5% in the H2 array approach for the PPI approach to lose its dominance over the H2 array strategy. So here, all that they are doing is they are just subjecting the base case to these changes to see how robust the base change, the base case is. It said other threshold values on cost were very unlikely to occur in order to alter results in any clinically plausible way. The hospitalization cost for no complication would need to be increased by more than 1,700 per day for the H2 array to become no longer dominated. So another variable that is sensitive is also the cost per day of the hospitalization of no complication. So if you change, remember that the cost per day of the hospitalization was this here. The next one is the length of stay. So the length of stay was also sensitive. If you change the length of stay, for example, if you change it by 60% in the, those with stress or bleeding, and then if you drop it by 40%, then it will change the base case. But without that, the PPI still remains dominant. They also did probabilistic sensitivity analysis. And in this case, they did incremental cost effectiveness plane. And they also did, so this is the incremental cost effectiveness plane here. And they also did cost acceptability curves. And this is the cost acceptability curve. So you have to know these ones. I think we'll have the article with us, so just don't worry about this. You just have to know that gamma distribution was used for the per diem cost and then the length of stay, and then the beta distribution for all the probabilities. PPI treatment was dominant in 49% of the simulation and remained effective. So let me show you where it says 49% of it is dominant. So like I showed you in the other graph, you see I drew this line here. It means that when they did the multi-way sensitivity analysis, they saw that 49% of the simulation falls under this plane here, the quadrant 2. So 49% means the PPI was dominant 49% here. So that's why I wrote this quadrant 2. I wrote this one here. Okay, and then they said that and remain cost effective in another, so remaining cost effective in another 9% of the simulation. So I think that one is here. So 9% of the simulation here is still cost effective. So it falls here, 9% falls here. And then the 47% falls here. And they did for the cost, the incremental cost acceptability curve. It's just another multi-way sensitivity analysis. That shows that, for example, if you are willing to pay a certain amount, which of the two options would you choose? And in this case, this is the probability of cost effectiveness. So in this case, we are looking for a bigger number. We are looking for example, the probability of cost effectiveness. If the probability of cost effectiveness is 100%, then it means that you are sure that if you give this drug, it's going to be cost effective. If the probability of the drug is, for example, 0%, then it means that the drug will not be cost effective. So here we are looking for a bigger number. So what we are looking for is that the amount, the willing to pay amount is normally 50,000. So if it is 50,000, what option will you choose? So in this case, we will choose the option of the PPI. That's why I drew this line here. So if you are paying 50,000, we will choose the option of the PPI because we are 55% sure that the PPI is cost effective. But for the H2RA, we are about 45% sure of cost effectiveness. So our option will still be the PPI. So that is what he was talking about here. And yes. So this is everything about the method, the table. So remember that this is two-way sensitivity analysis. It is two-way because we varied two variables here and then there. This is a multi-way sensitivity analysis. We do this for willingness to pay, that is cost acceptability curves. And then they will give us, so for example, you can say that if you are willing to pay maybe 25, for example, if you are willing to pay 150,000, which one will be your best option? So this one will be our best option because in this case, we are looking for the highest probability of cost effectiveness. And in the base case, they said the H2RA is dominated because in this case, whatever you are willing to pay, you still choose the H2, you still choose the PPI instead of the H2RA because the H2RA is dominated and then the PPI is dominant. What else? What else do I? Let me look through my notes if I have something else that I want to talk about. Yes, so that is everything from my side. If you have any question, let me know.
I have a question, Milton, sorry. So based on this study, we will add or know the PPI in the formulary or the...
Yes. So based on this study, our option is the PPI because that is what is less, this is, remember that this is more better because this is less expensive, more effective. Unlike the previous studies that we did in class, normally it is more expensive, more effective. But this one is less expensive, more effective. So this is the best option for the formulary. If you are supposed to add any one of the drugs to the formulary, this is our best option. And does it answer your question?
Yes, thank you.
Welcome.
Milton, when you're done with the recording, is it possible you can email us the recording, please?
Okay, I'll try and do that.
Okay, thank you. Do you want us to put our email in the chat?
Maybe. Who else has any other questions? You can, for example, you can ask questions that are not related to the article if you want.
So today, Dr. Perez mentioned that we have to search the, I think the data source for the C is perspective or retrospective or observational. So
for example, I did that for you guys already. So for example, this particular one, the nationwide inpatient sample was retrospective observational. The difference between retrospective and then observational and then interventional and then efficacy and effectiveness. So for the observational, we don't give any intervention. We just observe patients. So for example, in this data source, all they do is that they observe patient that comes into the ICU. They don't do anything to them. They just observe them and then they record it. If it is observational, that's what they do. If it is retrospective, they do it, they look back. They look back in retrospective. If it is prospective, then it is, they take the data as the whatever event, for example, in clinical trials, they take the data as the process is going on. So that is prospective. This is retrospective. The patient will come into the hospital and then they will report them. So for the observational, there's no intervention. They'll just more like describe what is going on. For interventional, which is the clinical trial, they will give you a drug. After giving you a drug, and then they will measure the effects. And so that is intervention. For efficacy and effectiveness, efficacy is just checking the effectiveness or the outcome of a drug in a controlled environment. So in clinical trials, after the clinical trial, if they get to know that this drug is able to treat this condition through clinical trial, that is efficacy. If they finish their phase 3 clinical trial and they do the post-marketing surveillance, that's when they give the drug to everybody. They don't do anything to you. They don't check up on you. They don't do anything. That is the real world efficacy. So that one is effectiveness. So the difference is under controlled environment, it is called efficacy. And then in the real world environment, it's called effectiveness. So that is this. So this is the one I found. But there are others. For example, you can look for Agency for Health Care Research and Quality. You can look for whether it's retrospective, prospective, or whatever it is. And then there are others as well. Let me check. And then, for example, they use these databases for the probability. So this ones I don't know. So maybe I'll check as well, but I don't know. I'll check maybe later. These are all data sources, so you can check these ones.
And Milton, this so type of clinical trial we in this study was like randomized trial was used, isn't it?
No. So in this particular study, they used randomized trials, but in the randomized trials, they used that to help with the diagnosis. They didn't use randomized trial for everything. So for example, this is why I've written diagnosis here. So we selected specific diagnosis to define a representative group of patients at risk of stress or subleading. The list of all diagnoses chosen was based on the included patient population from randomized clinical trial on this topic published in literature. So what they did is, when they were looking for, they had the patient from this group. They recruited the patient from the nationwide inpatient sample. That's where they have the data from. But when they had the patient, they need to diagnose them that, okay, so this patient should be diagnosed with VAP or it should be diagnosed with stress or subleading. In order to do that, then they used the randomized control trial. So the randomized control trial was just used to help with the diagnosis. That's all they did. Didn't do anything.
Okay, thank you.
And also remember that I was talking about the ICD-9 something. This is the ICD-9 code. So all these ones was used for, it was just to help with the diagnosis. So after getting the patients, they need to diagnose them. In order to diagnose them, they need to have a criteria, and then they use this and then the clinical trial to do it. So that's why they mentioned it. So we can search for whether this one is prospective or not. Okay, so somebody want me to repeat the tornado diagram again, then the multi-way sensitivity analysis again. Okay, so I'm going back to the tornado diagram. Okay, so with the tornado diagram, all that they are doing it, the first thing you need to know is it is used in one-way sensitivity analysis. Tornado diagram, one-way sensitivity analysis. And in one-way sensitivity analysis, all that we do is we take just one variable and then keep the rest constant, and then we vary that variable. So for example, this first one here, they took the probability of the VAP probability of the PPI causing the ventilator-assisted pneumonia. They just took that variable, and then they maintain all these variables, including the other ones that they didn't report this graph. And they plotted that's just this variable here. And then that's here. The next one is the same thing. They just took this and then they maintained all the other constants. And then they varied all this and then they plotted it. All that I want you to know to take away from this graph is that if you see the first bar here. It is the most sensitive. It is sensitive. What does it mean? It means that at some point, if you change the numbers, if you keep changing the numbers, at some point, the decision changes. And I explained that here, that the decision, remember that our base case decision is that the PPI is dominant, and then the H2 array is dominated. But this decision changes if you change this number here, this one, this particular one, 10.33, and then if you change 10.23, the 10.23 is for the H2 arrays, and then the PPI is 10.33. If you change those two, for example, if you change the 10.33 to 11.6, and then if you change the 10.32 to 9.9%, the decision changes. Now, the PPI becomes more expensive, more effective. It is no more dominated. It is no more dominant. It becomes more expensive, more effective. And then the H2 arrays, they are no more dominated. Right now, they are less, they are more, they are less, more expensive, but they are less effective. So it depends on whether you want to pay more for the effect or not. So they are no more dominated. Right now, they are more expensive, less effective. And the PPI is more expensive, more effective. So it depends. If you want to pay more, then you pay more. If not, they are no more dominated. So this result here is just confirming to us that this one is more sensitive, because if you change this and then if you change that, it changes the base case decision. So that is what they're explaining it here. This is the explanation. For the threshold analysis, I said that the threshold analysis can be used for one way, and also it can be used for two way. It depends on what was done. So you just have to look at the graph and then read the explanation here to know whether they used two variables or they used just one variable. So in this case, if you could remember, we've talked about the probability of the VAP in the PPI, and then we've talked about these are all variables in this research. So in this case, they use these two variables. And when they use these two variables, then just know that they are doing two-way sensitivity analysis, because in two-way sensitivity analysis, they vary two variables at the same time, and then they maintain all the rest at the same all the rest of the variables. So they vary two variables at the same time, maintain all the rest of the variables. So this is a two-way sensitivity analysis. Let me see if there are more questions in the chat.
Sorry, Milton. She said today that she will maybe change
The base case, and then she'll ask you to explain. So that is why I did this one. So this one I told that this is hypothetical. It's just me thinking about something. So for example, she can have a graph like this. And then the base case is this. So the base case was 10.33 and then 10.23 for the probability of the VAP and then the probability of the H2 arrays. But in the exam, she can say that the probability of the VAP, instead of 10.32, she can just say maybe the probability is 0.07875. And then the probability of the PPI causing the VAP is maybe 1.25. If she does that, all that you need to do is to plot the two on the graph and where they meet. So if you look at this legend, it just tells you that this part is for the H2 arrays, and then this part is for the PPI. These shadings just tell you when to choose which of the options. So if you plot and then it falls within this, then your best option will be the H2 arrays. If you plot and it falls here, then your best option will be the PPI. So that is why I gave this example. This is just hypothetical. It is me just giving this here. For the cost acceptability curve, remember that this is a multi-way sensitivity analysis. This is not two-way, this is multi-way. This is also multi-way. This here is also multi-way. This is multi-way. This is multi-way. So in multi-way, there are about 2 graphs that you need to know in multi-way sensitivity analysis. The first one is the incremental cost effectiveness plane, and this is the incremental cost effectiveness plane. And it is also called the Monte Carlo simulation or method. So remember that the incremental cost effectiveness plane is also called the Monte Carlo simulation. And the next one is the cost acceptability curve. This one, she's going to give you an amount. She's going to give you an amount. So she's going to mention that, for example, maybe 350,000. For example, if you are willing to pay 350,000, which of the 2 options will you choose? And our answer will still continue to be the PPI, because the PPI is dominated based on our base case. Do you have more questions?
So for adding formulary, if she changed the result that said, okay, the medication is more cost, more effectiveness, so do you want to adding in the formulary? We should say it depends, or
Yes, that's when you have to say, are you willing to pay, for example, S amount to get S benefit? If you are willing to pay that amount, then it's okay. So that is, and also that is when this graph, that's when they normally use this graph, this one, willingness to pay. So this graph will tell you that, for example, if you pay 150,000, which one do you have to choose? So normally, if it is in the first quadrant, that is more expensive, more effective, then that's when you need to do the calculation for the ISA and then decide that I want to pay S amount to get S benefits, or I don't want to pay S amount, so I'll take the one that is less expensive and then less effective. Nitra, does it make sense?
yes, thank you.
What other questions do we have?
Doctor, can I see the decision tree exercise for the H2RA, please? I'm
Okay.
confusing with one number with your
No
exercise.
problem. So let me share the other screen. So I just did this so that everyone will know where everything is. And then I went
Mhm.
to the Word document. Let me go to the Word document. So I went to the Word document. So this is, remember that I said we are not using these ones. This is the one that I was trying to
No,
do.
I'm saying number 3.
Number 3.
So 6.61.
Fine.
Why are you using? No, go
This
down.
the
No,
article or this one?
Oh, the article. I'm saying the article. So you use those numbers by
Yes.
yourself.
Yes, that's
Okay,
what-
okay. I got it. So that's why.
Milton,
Yeah, can I again?
yeah, can I ask you a question?
Oh.
Figure number 3,
Okay.
can you go to like probability of VAP in H2 and the comparison? So that dotted line and the
wait,
hard.
which one? Wait, figure 3.
Oh,
This one.
yes, yes.
All right.
So what if if we draw the graph and it comes into the solid line, then we choose the PPI if it is solid line?
Yeah, so look at this. They've defined everything for you. So here, look at this one here.
Mhm.
This is the PPI. This one, these striped ones are the PPI. And then these dotted ones are the H2 arrays. So in the exam, she's just going to give you 2 numbers. All
Okay.
that you need to do is to just plot the 2 numbers, and then wherever they fall, that is your decision.
Okay.
Does it
Alright.
make
Yes,
sense?
yes. Thank you.
Guys, I'm looking for more questions, and that is my part. That is the end for my part. So if you have any questions, let me know, and we'll talk about it. So
Thank
how do you feel? How do you guys feel? Do you feel confident about it?
Because of you, yes. Thank you very much.
Yes, thank you so much. Thank you for your time.
What other question? Let me see the chat if you have more questions.
Thank you so much.
Thank you, Milton.
Thank you, Milton.
So guys, if you don't have any question, then we would close for this meeting. And I will see you.
Thank you, my love.
Thank
my-
you, my dear
was-
Milton. You're the best.
I wish you all the best.
Thank
So
you.
where do I have to send the email?
Oh, you can send it through WhatsApp and I will send it to them
Okay, all right.
if you
Okay.
want. Yeah, send me the link on WhatsApp and I will send it.
Okay, no problem. Okay.
Okay? Thank you very much,
Okay.
Milton. You're the best. We love you.
Bye.
Bye.
Thank you. Bye.
Good job. Good job.
Jordan.
Yeah, what's up?
What's up, Jordan? What's up?
What's up?
I'm just passing through, you know?
Huh?
I'm
Anna,
just
don't
passing
charge
through.
them for the email.
No, he's gonna send me the link through WhatsApp and I will send it to you guys.
Okay.
Right, Milton?
Okay, guys, take care. Bye.
Thank
Good
you.
night.
Bye-bye. Good night. Thank you.